Hello, everyone, and welcome to New Horizons for Chronic Fatigue. My name is Dr. Ryan Christensen, and I'm a proud osteopathic physician practicing family medicine, OMT, and integrative functional osteopathy in Lake Orion, Michigan. And I'm here today with Dr. Mary Goldman.
Hello, Mary Goldman. I work at Osteopathic Healthcare Associates in uh, Sterling Heights, Michigan, and I do strictly OMT practice at this time. I am family practice boarded.
So, we're really looking forward to spending some time with you today, talking about some of our experiences in lymphatic medicine. And today we're going to talk about myalgic encephalitis, or also known as chronic fatigue syndrome, abbreviated here as ME/CFS, fibromyalgia, the chronic pain condition that so far is well described in the literature but poorly understood and even more poorly treated. And lastly, new since the pandemic, the effects of the long COVID-19 syndrome. And we hope today to share osteopathic medical insights and wonderful tricks for hands-on healing, both here and in our future. So let's dive in. And first, I want to show you something about what we notice.
This is an awareness test. How many passes does the team in white make? Go! The answer is 13. But did you see the moonwalking bear?
So it's easy to miss something that you're not looking for. And this was a UK ad for cyclists. But I really think this is very, very true and prudent when we talk about some of these conditions that are poorly understood and even more poorly described in medicine. Today we're going to talk through...
This is an awareness test.
Today we're going to talk through some learning objectives. And we're going to identify key osteopathic structural findings and autonomic and lymphatic patterns that we find clinically in people with myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia, and more recently, long COVID. We're going to demonstrate and teach and hopefully get you to apply some basic hands-on osteopathic techniques that can both support autonomic regulation and lymphatic flow. We're also going to enhance your clinical diagnostic accuracy for chronic fatigue syndrome and give you tools in the office in less than 5 minutes that you can screen for 2 clinical findings and with 80+% predictability be able to help point people to a clear diagnosis. And we're going to talk about and hope you understand a little bit more after today the lymphatic system, a newly described lymphatic system in the brain first discovered in 2016 by Dr. Jared Iliff, but really known to osteopathic physicians for about 150 years at this point, and its role in health and disease. So join in, get your ball. We're going to have a really good time. And these are our puppies, and we're excited to be with you today. So let's talk about fibromyalgia. This is something that every primary care doctor struggles to treat. There's limited resources, there's limited research, and despite our best hope, it seems that people are getting diagnosed more and more with this, what it was been considered, as I was a residency director and teaching about this a lot, it was kind of a trash can diagnosis, for lack of a better term. Patients, often women, often at changes, different pattern changes of hormonal times, in adolescence, young adulthood, or sometimes at menopause, would get all of this widespread, all 4 quadrants of their body chronic pain. And how many people remember the rheumatologic criteria, all the trigger points and tender points that you had to count the number of diagnoses to make this diagnosis for a very long time? And fibromyalgia, fibro, meaning the connective tissue, muscle, algia, pain. So pain in the muscle and connective tissue is what I want you to think of when you think of fibromyalgia. Its hallmark is pain in all 4 body quadrants. And that's really important, okay? Because if you divide from a belly button like a 4-part piece, and notice what happens if you can point and say, oh, do you have pain really bad in your shoulders and your back and your hips? Which many of my patients do, but most of your like low back pain patients, it's very localized. These patients are going to describe stiffness, back pain, muscle spasms, neck and nerve pain, electrical shocks and sensations. Sometimes this is going across autonomic patterns as well, but we see here in fibromyalgia that this is a pain predominant feature, okay? There will also describe, and we're going to go to the middle of the circle here where the Venn diagram crosses over, what's shared by both diagnoses here, and that's chronic pain, widespread body aches, fatigue, depression, brain fog often, insomnia, muscle aches and headaches, irritable bowel syndrome or symptoms, including diarrhea or maybe constipation. Migraine is very co-presenting with these patients and also has a bit extreme disability of its own. Joint pain, exhaustion, restless legs, anxiety, and memory loss. And you know, that's a pretty wide list that affects a lot of systems for people. And then lastly, as we talk about ME/CFS, myalgic encephalomyelitis, which is an important distinction, we'll talk about that here in a second, and chronic fatigue syndrome, though, on diagnosis, needs the hallmark of post-exertional malaise. Now, let's break that one apart, okay? Post, after, exertion, malaise is like a flu. Malaise is that feeling when your body hurts so bad, like maybe you're really dehydrated, like me today after a long week, and you'll get this onset fatigue. For these patients, they're going to come and tell you like, okay, doc, I went to an event like a picnic or a baby shower or something on a Sunday afternoon. And then Monday they said, I felt okay. Like they might have been good even in their, usually they have some burden of disease. But they would then say like Tuesday or Wednesday, I just crashed. I couldn't do anything. I couldn't get up out of bed. I didn't want to have any energy. Many people, though, that are the high achievers that tend to get this diagnosis push through that. And most commonly, we see the fatigue on this side predate any of the pain symptoms of like fibromyalgia. So there's delayed onset fatigue and extreme tiredness. And I experienced this as a patient after long COVID. And it was so fascinating to me. All of the guidelines so far have talked about graded exercise. These patients are going to tell you if they try to work out, they get punished. And many of them are like really high level athletes, achievers, performing artists. I mean, think gymnasts, dancers, CEOs, doctors, nurses, like people that are like nurses that are marathon runners, right? And they're going to complain to you in the clinic of fatigue. Fatigue is going to be the predominant concern. And this is crowdsourced data from the community, so it's been very interesting to see how much of this does fit into our diagnostic criteria. So there's some big challenges here. And let's talk about the clinical challenge. There's a lot of overlapping features that have diagnostic challenge and difficulty. And first, those are things like severe fatigue with this post-exertional malaise. And I think it's important because these patients aren't going to come asking you for opiates, typically. They're not like trying to get out of pain. They're trying to get back to whatever function they aren't able to do. So they're going to complain of widespread pain and muscle tenderness, brain fog and unrefreshing sleep. We see a lot of circadian rhythm dysfunction in these patients and lack of REM sleep, the deep restorative sleep. Many coexisting folks have autonomic symptoms. And you may have heard of POTS, or postural orthostatic tachycardia syndrome, IBS, irritable bowel syndrome, or orthostatic intolerance, like things like inappropriate sinus tachycardias. And these are folks that usually make it to cardiology. They get worked up appropriately with a Holter monitor, an echocardiogram. They're screened for symptomatology. Sometimes they will feel this or notice it on smartwatches or on smart rings or different devices that monitor this. But you'll see an inappropriately high heart rate response for minimal exertion. Or sometimes like even with like startle or other pieces. And one of the patients we may talk about today at the end in our patient stories is a financial advisor who, had some type of AFib episode that was kind of initially attuned to alcohol, but then started getting a lot of these inappropriate tachycardias. And so typically the patients respond with beta blockers. There's ibravadine, which has newly been discussed. It's a heart failure drug that is being used with quite success for these autonomic patients. But it's really limited on the drug side because we understand that this neuromuscular junction, that this osteopathic nerve flow that we've talked about is affected by this. And that's why I want you to think of the sympathetics throughout the spine as well as the parasympathetic nerves. There's a lot of crossover, and our studies now are showing that those small fibers are really affected. You'll also see this more commonly in people that experience their disproportionate share of trauma. Those are folks with low social determinants of health or people with lack of support and resources. We think the brain is upregulated to feel more pain as well, and part of this autonomic stuff and what we talk about a lot in the trauma-informed care that we do is about establishing safety, okay? The nervous system has to be safe to fire the new change. And what we're going to do really hopefully today is shift our paradigm from this description of a vague fatigue that like overwhelms your office visit to some clear questions that you can ask, like, do you get this delayed fatigue thing after you or crashes? And then ask them what they experience. The other thing to do is validate their illness. Many of these people are sent immediately to psychiatry because physicians, caregivers don't believe that this is a real disorder. So clearly from the community, we've heard over and over and over again, I'm not taken seriously. And we'll talk about the drug options for this. But for those of you in primary care, for those of you in busy patient-facing specialists, hospitalists who are often asked to care for these patients inpatient with a lot of extra burden, I want to make sure you know that there's places that you can send them for evidence-based care that's going to work them as slowly as they need and hold them as tenderly. And that's what we'll talk about, some of the resources through with the parent technique and other neurolymphatic mechanisms through osteopathic hands-on medicine. These are complex patients, and I don't have answers. I have many, many, many more questions. That there's many more needs that are not being addressed for this, including nutritional support, protein in the diet is very important. Removing toxins, because we see that the exposure to different things and with our recent discussions on microplastics and other things that are affecting not only our brains but our bodies, I think it's really important that we remain as humble as we need to as clinicians, right, to listen and serve the patient. And it's truly the osteopathic perspective and osteopathic way is that we believe our patients and that we really want to help them get well. And I'm really excited to share this with you because I think we can take this from a huge challenge into a huge benefit. Because right now, our current standard of care is duloxetine, which is the only FDA-approved medicine for fibromyalgia. It works really well at about 60 milligram, which is the second dose up in the scale. Usually we start at 30 milligrams once a day, duloxetine or Cymbalta, and then we can, after about 2 weeks, double it. It's a very long half-life. So if you taper this, which I do often for people, up and down, you really want to go slow. And I change the dose over a month, and then I take them down over 2 weeks, and then I have them do them every other day, and really, really go gentle on those norepinephrine receptors. Serotonin, the sunshine chemical, is part of this, but mostly it's norepinephrine mediated. And that's kind of like getting you out of bed. And when we talk about, again, I just want to remind you, fibromyalgia is pain in all 4 quadrants. And it's a pain predominant diagnosis where ME, myalgic encephalomyelitis, and let's talk about that. Myalgic encephalo, so the muscles and the brain. Encephalomyelitis is the brain and its coverings, the myelin on the outside, including the dura mater. And we're going to talk today also about some new discoveries in the science of the brain that I'm really, really excited to share with you, especially the new membrane we found in the arachnoid, the SLIM. Remember, exercise will worsen PEM. We recommend pacing as first line. And I'm going to give you a little foreshadowing and answer to the test question in the back. Pacing is doing 50% of what you're capable of doing. So what is our clinical challenge? Delayed diagnosis. And this is where my heart goes out to you, and I'm asking you as my dear colleagues and friends and people on the internet who are hopefully watching this someday to actually start to understand what the diagnostic criteria are and why we need to help people find this. The diagnosis of ME/CFS meets the core criterion of a fatigue predominant complaint plus that post-exertional malaise for greater than or equal to 6 months. Most people experience that significantly, including after COVID, even for a temporary time before it resolved. But still, we found a delay to diagnosis of 1 to 3 years. For people who have the pain predominant version, that's fibromyalgia, and that can be diagnosed by widespread pain greater than or equal to 3 months, which meets the chronic pain criterion at this point. Is if you have daily pain at 3 months, we see it changes the brain, actually. And it's really, really sad. It actually activates the emotional centers instead of the pain centers. Neuroscience is starting to show like not only why opiates and benzos are so dangerous, but because these delayed diagnoses, people don't have the tools to start to address the mechanisms underneath, and then they get sicker and sicker until they end up in my office. And the ones that have been coming in droves, not only from the infection itself, but I've seen some people have the spike proteinopathy from immunization, is long COVID. Now, COVID or post-acute sequelae of COVID, they described this, is prolonged symptoms, or in many of our cases, a symptoms and then a resolution and then a recurrence of symptoms that were greater than 12 weeks post-infection. Because of the awareness around this, many people were like going to their clinicians and asking for diagnoses and getting it. But long COVID clinics filled up around the country, and there was a very limited resources, and there still is, truly, to treat this. We think of it kind of in the spectrum, but it has some unique signatures, including a sludginess. Like you'll almost palpate this in the cranial mechanism, but it'll feel the microclotting and then the widespread vascular inflammation. Tools like nattokinase have been helpful for that, and some of the clotting reduction pieces. People will see that increased clotting risk after these things. And we see, though, that infection is a major and core cause. Some of the research, we heard recently about multiple sclerosis being associated with Epstein-Barr virus, and we're seeing that with chronic fatigue syndrome. About 80 to 85% of our patients, when we run the Epstein-Barr panels, which I include in my initial fatigue workup, and we can talk about what that labs look like and what we test for, is the infection is one part and is resolved, but the spike protein that happens afterwards, many labs won't result this in a level like the mark greater than 2,500 or the greater than 1,000. And I've had patients who have come to me and we've found it in 30 to 40,000 spike protein levels. So there's some discussion about whether, like for long COVID, we should be filtering the blood. But we know these infections, right? And think about infections. Think about the immune system, those little white cell friends coming in, dumping all their granulocytes, pulling in the interleukins and leukotrienes, right? What are they going to do? They are mobilizing the troops. They are going to fight that. And what happens after we fight? There's a battlefield left, right? We got to clean it up, okay? Whose job is to clean up from those infections? That's the lymphatic system. And that's one of the big core pieces that we're understanding with our understanding of ME that's evolving, is that this lymphatic mechanism as part of the vascular system is truly impaired. As I mentioned before, these patients are also a little more type A. They tend to be the people that carry their stress, to be the high achievers, and to be the ones that are caretakers, people pleasers, or helpers, or known as the empaths. We also see a genetic component to this and some associations with hypermobility and Ehlers-Danlos syndrome. But the genetic factors, we can start to see there's a lot of places for research here and how different people, including folks with different methylation problems, process this differently. We understand that chronic fatigue affects the hypothalamus. And I want to remind us, here's our skull. And as we're talking about this cranial mechanism, we're looking right here inside the little sella turcica is between the sphenoid bone in blue and the occiput in purple. And remember, here's our bottom of our skull. So this is what we are actually seeing and talking about with our cranial mechanism. And when that cranial mechanism is moving correctly, it's actually, this hypothalamus is riding up there on that, above the pituitary gland. And so the relation to this, to the anatomy we're dealing with osteopathically, is a really important point that I'd like to emphasize. And now we'd like to talk about some scholarship of a really cool clinician that I'd like to share his information with you, Dr. Raymond Perrin. And Dr. Perrin is a British osteopath and DO PhD in neuroscience from the University of Manchester, who started discussing and discovering some of these tools after taking care of a patient in about 1989 as a sports osteopath, when one of his road bike racing patients had a devastating crash, and about a month later he was unable to get out of bed. And Dr. Perrin got really interested in this and started understanding and kind of formalizing some theories about this that we're going to talk about, that some of the research has been really cool to see where it goes. And he's termed this the Perrin technique. So let's talk about what is lymph. This little video I want to show you. So this first one is an ultrasound of the neck up here, left side, and it's showing the thoracic duct into the venous angle. And look at that normal flow right here. It's moving nicely through, sorry. Video 2 here. Now notice this one, kind of sticky, not really pushing through there into that subclavian. We're going to talk about this anatomy here, but it's really important because this is the last common pathway. This is the drainage point where the lymph returns back to the vascular venous circulation to be down the subclavian into the first pass metabolism primarily and then out. And that first pass reminder is the liver that gets hit with all of this deliciousness. The lymphatic system is what we're going to talk about right now. And the lymphatic system is important for the white blood cell development of the lymphocyte and facilitating our immune response. That little army I was talking about earlier. The lymphatic system also has a cool, wonderful picture of reabsorbing excess interstitial fluid, returning it to the venous circulation, and that maintains the blood volume of our kind of open circulatory system. That's where it draws from the tissues. And it also prevents the interstitial fluid levels from rising out of control in conditions like edema or lipedema. It also transports dietary lipids. So we see this impaired with people with different obesity problems because these lipids are transported through the lacteals and they drain into the larger lymphatic vessels and eventually back into the bloodstream. I want to remind you too about the thoracic duct. And the thoracic duct, as this picture shows, comes up from the cisterna chyli. The cisterna chyli is the gathering of all of that abdominal and lower extremity lymphatics that is coming up through the central part of the lymphatic chain. About at the angle of the ribs is where the azygous veins and tributaries are. We start to see the lymphatics coming off the organs. And there's a big one for the liver, for the heart, for the kidneys. And then as we go up, you're going to see that tracing backwards, round, and it actually punctures through Simpson's fascia in the front and then goes around kind of curlicue and comes over and behind and out the subclavian vein. I know, right? It's wild. And we're going to draw a little more picture. But that thoracic duct is what we're talking about, that main central lymphatic drainage. And as it comes through at the root of its neck, it turns laterally, arches forward, and descends abruptly into the left venous angle. And before termination, it receives the left jugular subclavian and bronchomediastinal trunk. And one thing I want you to notice there is how close is that to the spine, even in this artist drawing, and in the ribs, and the heads of the ribs, osteopathic physicians. That's important. So, isn't this amazing? See how it draws up and over there behind, and this is where it's piercing through Simpson's, and then it comes back down and around in front into there. And I think it's really, really important to see that and understand that mechanism and direction. And here I want to show it to you again on autopsy dissection here from our fascial friend Gil Headley. And you can see it's pretty small. One thing that happens with the lymphatics is, when do we detect them? We detect them when they're abnormal. And when are they abnormal? They're abnormal in infection, right? Let's think strep throat, anterior chain adenopathy. You feel them backing up. When else can you feel them? You can feel them when you're doing, when it's cancer or lymphoma. You can find it when there's an area of infection more distal to that. So it can be a sign that's like showing you this growth. And that anastomosis of the thoracic duct and the venous drainage, and this is one more piece, I just want to show you that angle as it comes around and it drains in. And one more time now, with that anatomy in mind, I want to let you watch this. So there we go, there's our thoracic duct, pretty brisk. And there's almost a sucking motion that the veins do. And here you can see how it's just not quite able to get through. Our hypothesis is that this central lymphatic drainage is affected in chronic fatigue syndrome. And we're going to show you some physical signs that demonstrate that, and talk a little bit more about what this all means. So now, what are lymph nodes? Lymph nodes are the little hearts of the lymphatic system. They are the armpit lumps that you'll see in diagnosis caused by these swollen lymph nodes. But there's between 450 to 800 in the adult human person's body. And interestingly enough, from the breasts, about the ribs, over to the earlobes, in the cervical area, is half of those. Or 60%, 300 of them on average. There's about 20 to 30 nodes in the axillary region, so this is important. Most of our breast surgeon colleagues know this. And you can see the lymph node dissections that are done in breast cancer are affected by this. In the mesenteries, in the abdomen, you'll see another large number, and this is where the cisterna chyli is. So those mesenteric lymph nodes and lymph vessels all go in together, about 100 and 150 of them. And as you can imagine, as we go more distal down, the inguinal area is 4 to 20 lymph nodes. And, think about the people that have seen lymphogranuloma venereum or like large lymphadenopathy down there. You know how big some of those lymph nodes could get if they needed to. Remember, these are living, breathing tissues that are responding as best as the body can to maintain its homeostatic balance and its allostatic load in the environment. And behind the knees, the popliteal, there's 2 to 9 lymphatic vessels. I think it's really important, too, that we understand that these systems, lymphatics work on negative pressure. They actually work on drawing the tissue, the fluid. And remember from physics, we talked a lot about, and chemistry in high school, we talked about concentration gradients, right? So where things build up, they will be pushed to areas that have less of it. But we found that it's not even just driven only by that mechanism, that it's actually deeper and even more robust. That the extracellular matrix, and this is the beautiful mechanism of our membranes, pumps fluid into these lymphatic vessels. That within the lymphatic vessels themselves are contractile filaments of actomycin that are attached to the terminal lymphatics, and there's a baseline rhythm and a rate that rhythmically push lymph into the lymphangion. And some of the central lymphatic data shows that that's about 4 a minute, and it's probably part of what we're feeling and sensing with our osteopathic hands in treatment. The lymphangion is the little heart of the lymphatic system due to the peristaltic motion it produces and the role that the T-type calcium channels play in lymphatic pacemaking. So this is all affected through the autonomic nervous system, sympathetic, fight or flight, or the rest and digest to the parasympathetic, the body temperature, which is a big driver. And you'll notice that too with your folks that are driven by histamine-based conditions, anaphylaxis included, that as the temperature rises, your risk for that response increases. Caffeine and hormones affect these contractions dramatically as well as stimulants in other ways. So we'll see it really affected by some of the ADHD medications and some of the anti-fatigue medicines that are used, as well as things like cocaine. But I think it's important to recognize that this system is not just a passive observer. And if you're seeing signs of this lymphatic dysfunction, think infection, think cancer, but also look at these deeper things like that might be happening to, like chronic fatigue syndrome. And I have a really cool video that I'd like to show you of a lymphatic vessel. So you'll notice the membranes here, and you'll see how close the blood flow is. So you'll notice those little capillaries around. So here's the fluid coming back in, and you're going to see it kind of relax. And here's our filaments. Squeeze, pushing those through, and then you'll see it as it relaxes, it draws the fluid in. And so this is like a concertina effect. It's siphoning and suctioning that fluid up. Also the valves, right? So here's the valves in the lymphatics, and I'll play that again while it goes. So the valves in the lymphatics, we think what's happening is either the lymphatic gets stretched out so much that the valve becomes incompetent and it kind of pushes back and forth, or that there might be something like in the glycocalyx or in the membrane that's affected by that on the side of the membrane. So you can see what a normal squeeze looks like of that terminal lymphangion, though. Isn't that cool? I just think the human body is so fascinating. Thanks for listening to our talk today. And I want to speak a little bit about the lymphatic drainage, specifically in the brain. And the brain, again, is built around the skull. And we find that a lot of the stuff that we're realizing has to do with the now 4 places we understand CSF to leave the brain. Number 1, and actually the largest proportion with around 60%, is right here at the base of the nose, deep into the skull a little, into the cribriform plate. The cribriform plate, again, are those nice little holes where those cranial nerves of the olfactory nerve come out. And down here, you'll see this in this nice image is number 1. Number 2 is the cranial nerves. And around the cranial nerves, we're going to show you some fun new data that shows what tracer is shown around the nerves, and that the CSF system is really contiguous with that. And number 3 is the meningeal lymphatics. We have a whole new system to share with you that's been found on gross anatomy called the CSF canalicular system. And you'll see this area of the dural sinus, which we often treat with our hands in the venous sinus drainage technique, the CV4, and other hands-on osteopathic techniques, are really affected and improved through this mechanism. And number 4 is the spinal nerves. These are the nerves that exit around the base of the skull, around the jugular foramen, and go down through around different spinal nerves out through the dura. More in the periphery, though, or more distal than in the central brain area. So we found that the CSF in the subarachnoid space is a fluid source for the lymphatics. And then CSF goes to the perineural sheaths around. And this was found by Rasmussen at the University of Copenhagen and Melken Nedergaard at the University of Rochester. And let's see a little bit more about how this moves through the brain. As it comes through, we talked a little bit about that cribriform plate, and this is an inside picture of it from Dr. Perrin's work, that the arterial supply and venous return go down, but also the nerves run down, and everywhere that comes through there is actually circled by this green in the picture, which is tracer that actually has nasal submucosal lymphatic fluid, which now, because of Nedergaard's work, we know is contiguous with the cerebrospinal fluid. And this is why when you break that blood-brain barrier, why that infection goes so deep so fast, right? Those deep meningitis infections or encephalitis, like because of this membrane. And this is that blood-brain barrier. So I'll show you this in a different way. Here's the inside of a blood vessel up here at the top, and we're going to blow up this tight junction. And that tight junction right here, you see the blood vessel, the blood-brain barrier. It's an endothelial cell in the tight junction in the basement membrane. And then deep to that is the brain tissue, the astrocytes, the microglia. And when we look at that blood-brain barrier, we can see then, this is from Dr. Illiff's work, we'll talk with him here in a minute, but they'd used radiotracer in the cerebrospinal fluid, and then they traced it down around the nerves. And this is what the image showed. Here's the green that goes around, and there's the blood inside here in the black. The endothelium is the white, and the smooth muscle cells stain here in red. But the green is our cerebrospinal fluid and that drainage of our lymphatic system. This is lying here between the dura and deep within the arachnoid, here in the perivascular space. Down here is the subpial space, and then back to our perivascular space and into the sulci. So, as the meninges move, we're going to also zoom in here on the structural features of the central nervous system vessels. And we found deep here there's also the brain's own lymphatic vessels coming out to the surface. So exciting. Now, this is one of my favorites. This is the slim. And if you cut off the top of the brain and you look in there deep in that arachnoid layer, turns out that there is a separate membrane. But let's watch Dr. Iliff, and I'm going to get back into that in just a second.
The brain's highly metabolically active. The brain cares an awful lot about what its environment is like. If it's off just a little tiny bit, it stops functioning properly. We showed that the CSF goes into the brain just like people thought before, but it actually does so along very specific anatomical structures. There's a specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system for clearing the fluid and the waste out of the brain. We injected fluorescent tracer into the CSF, or the fluid that surrounds the brain, and watched to see where it went. The fluid, as it moves down the artery, is able to move right into the brain tissue. As it moves into the brain tissue, eventually, if you look long enough, where it collects is at the other end, at veins, which are another part of the circulation. Once it reaches those veins, it's able to drain out of the brain along the outside of the veins. As the fluid sort of courses between those two, in along the arteries, through the tissue, out along the veins, that continuous flow sweeps along particles that are sitting in between the cells. Amyloid beta is a protein that is made and secreted from cells in your brain all the time. In Alzheimer's disease, one of the things that happens is amyloid beta builds up in the brain and clogs up the space in between the cells. And it's thought that that's what kills the neurons and causes the dementia that's the hallmark of Alzheimer's disease. So when we first found this system and found that it was clearing extracellular solutes, we said, well, what solutes might be of interest that might be being cleared by this? And when you think about extracellular solutes that the brain wants to get rid of and needs to get rid of, the first thing that comes to almost everyone's mind is amyloid beta. So that was because you suffer an injury or an infection at some point in your life. Maybe this pathway stops working properly, and that ends up causing the deposition and the accumulation of amyloid. For treatment, it suggests that you could slow the process of amyloid deposition, perhaps by speeding the system up and sort of flushing the brain out and getting rid of the amyloid before it accumulates. And if you had, a brain that had a bunch of amyloid that had already accumulated in it, perhaps you might be able to flush that away or wear away those accumulations with a higher rate of flow. So we may be able to try to modulate or change how this system functions to try to clear it more quickly.
I just think that's super, super exciting. And I really wanted to show you that because our understanding is that this glymphatic system is so key to so many of the diseases that we've yet to really understand a mechanism for the pathogenesis. And we have a lot exciting more to share with you here. But that glymphatic system, and you may have not heard the term glymphatic, which has become a little bit more popular, but is still not really being discussed. That within the description of the glymphatic system is this new found membrane. And this was described by Dr. Melgard, described in Science in 2023. So you're not missing out too much, doctors, because as I said, this is really, really new science. And so it's really an honor to get to share this with you and enhance your patient's experience by really understanding that we're on the front lines of neuroscience. And in the osteopathic profession, I'm so proud to be a DO that we felt this through all of our training, through the cranial mechanism, back to Dr. Sutherland's work, to Charlotte Weaver. And I'm really excited for people to learn how they can apply these techniques within their skill sets and use this to help people get well. So the SLIM, this extra layer lines the brain. And our traditional view is that there's three membranes, right? The dura, the arachnoid, and the pia. But Dr. Melgard found a fourth meningeal layer, known now as the subarachnoid lymphatic-like membrane, the SLIM. The SLIM is actually immunophenotypically distinct, and that's under the microscope that it doesn't glow the same from the other meningeal layers in the human and mouse brain. And they describe it representing, so far previously poorly described and understood, tight barrier for solutes of more than 3 kilodaltons. These are supplements like hormones, insulin, that needed to cross into the brain, but we didn't understand how they could get in. The SLIM is our key. So this effectively divides that subarachnoid space into two separate compartments, an inner, more concentrated, or an inner, more clean, smaller molecule, and a larger outer molecule. So the SLIM is also an immunologic organ. It's a host for a large population of myeloid cells, the number of which increases in response to inflammation and aging. So it finally answers our question, where is the immune system in the brain living? And it's ideally positioned within the arachnoid to surveil the spinal fluid and pick up on some of these signals. And I think this is a beautiful place that we could start to understand. Maybe this has some sensation. Maybe this has some different effects than we understand. And again, new amazing science. So why hasn't it been discovered before, Dr. Ryan? Well, good question, doctor. It's extremely thin, with a width of just a few cells, or even places just one single cell. The SLIM hadn't been noticed before, partially because the membrane disintegrates, good word, when the brain is removed from the skull in postmortem. And that's the piece that I want to remind you is we're intimately connected to these bones. From the membranes that formed us to all of the hematologic and immunologic processes the bones do, the reforming. I mean, our orthopedic colleagues know this, they love their hammers and nails and putting it back together. But this is such living tissue, folks, that I really hope you can appreciate that the closeness of the SLIM as well with the endothelial lining of the meningeal venous sinus, now we're going blood vessels, permits direct exchange of solutes between the CSF, cerebrospinal fluid, and the venous blood. Wow. So those systems are really interconnected. And this membrane, the SLIM, subarachnoid lymphatic-like membrane, provides the foundational insights for these brain immune barriers and fluid transport. Wow. So let's dig in even a little deeper. And I want to show you the image of our current CSF understanding. So here's that subarachnoid space we were talking about in the yellow and our sagittal sinus. And on the right side, our cross section basically shows the CSF, which is in yellow, draining from the subarachnoid space back through the arachnoid granulations into the superior sagittal sinus and vein, right? And sagittal sinus blood exits the cranium through the jugular foramen to enter the internal jugular vein. Notice here in this image, there's no connection between the yellow here. And that's our current understanding that I hope you may entertain a new option here in a minute. So, enter one of my heroes, Dr. Joel Pessa. He is a private practice in Arlington, Massachusetts, and he was doing a surgery and saw some tubes, and he actually traced them down and put in some tracer. And this is his article that I think is required reading for every physician and medical student and trainee, truly talking about like how easy it is to miss things right in front of our face. But we know obstructed CSF drainage results in increased intracranial pressure. So our current model suggests CSF drains right into the sagittal sinus, but they actually found in a human cadaver a new system. Let me show you. So we're going to cut through right here, right on the top, and we're going to dissect down to the venous sagittal sinus. It's a midline venous structure between the areas, and it lies within the dura. What we're going to do is we're going to dissect down into that and open that up here. and we're going to be on either side, and you're going to see a couple of channels on either side here, and this little clear tube. Look at this tube, beautiful. You can see the fascia, how it's suspended in there. Anyway, I love to point that out. Look here on the left side. I'm going to blow this up. And right in there is this little tiny clear tube. And the macro view on photo of a CSF channel in that arrow. Now we're going to cross section that and look over here. So you'll see the superior sagittal vein. Arrow on the left is you'll see it's obstructed because of a tumor, I believe. And on this right side, you can actually see it, the patent opening. So what did Dr. Pessa find? The cerebrospinal fluid canalicular system, an anatomical route directly from the arachnoid meninges to the subclavian, independent of the venous sagittal sinus. Wow. Wow, Joel. Okay, it's privileged. It's a direct route, and it may be a primary path. It drains straight to the subclavian. Its terminal CSF drains to both the brain and nerves, and it's embedded in a canalicular structure and surrounding tissue. It's a plexiform, so it travels as a group of channels, and they lack valves and a muscular wall, and they're usually single cell layered thick, is what he found. And let me show you. So they dissected all the way down into the neck. And as you read the article, you can see he'll put radio tracer through. And here, let me show you the redrawn image. So right here in this little triangle, you'll see the CSF canalicular system traveling right there in the falx. And as it comes down, we can see that drainage here. Then we also see perforating lymphatic vessels and continuity down along the internal jugular vein through the canalicular system. And this will be through our vertebrovenous plexus as well, down through lymphatic vessels and out through that lymphatic duct. So our current understanding here on the left is the vagus nerve. Here's our current understanding of the lymphatic system. And I'd like to propose you to think a little bit more like this picture on the right and notice how much more our crossover is starting to look like the actual anatomy of the brain. Because I think the nerve and the blood vessel are intimately connected in ways that we don't yet completely understand. And through perivascular spaces and through this really emerging beautiful science that I think osteopathy can lead, we're really in a place to start to discover, discuss, and study this and how it affects human health and disease. So after we found it on a patient, we need to prove it because we're good scientists, doctors. So this is our proof on MRI, non-invasively, that human and non-human primate meninges harbor central lymphatic vessels. And this was in 2017. Pre-contrast, you can see post-GAD, there was a little light up, and when we magnify that along the dura, it lit up, and there's lymphatic vessels here in the bottom right that timed correctly with our view of contrast. And then we finally did a 3D rendering, and this is one of my favorite slides, I think, ever, of dural lymphatics. And you can see that area of the venous sinus on this posterior side of the cranium. And you can see how that's all so much affected by what we're learning. One more time, I'll show you that. What's the best way to affect this system? Let's talk a little bit about clinical as we describe some more anatomy. That it is the norepinephrine mediated slow vasomotor changes that drive lymphatic clearance during sleep. So there's our friend, back to our drug tie-in. Remember our SNRIs that we talked about earlier? Yeah, it's pretty fun being a doctor, isn't it? That norepinephrine release from the locus ceruleus, which is in that hypothalamus area, by the way, drives slow vasomotion in non-REM sleep. So those little slow oscillations of the norepinephrine change blood flow and cerebrospinal fluid volumes. And how did we find that? Well, we put in a little probe into our friends, and we watched. And we saw that this cerebrospinal fluid volume and fluid promoted the lymphatic clearance. Optogenetic and pharmacal manipulations confirmed that vasomotor, regulated by norepinephrine, acts as a pump for brain fluid transport. That's 2025 data. So one thing this study found I thought was really, really curious and interesting, as many of us, myself included when I was doing a ton of shift work, use the medicine Ambien very frequently for sleep. And some people will say that they need that in strongly benefit from it. The sleep aid zolpidem, Ambien, suppresses the norepinephrine oscillations in lymphatic flow in every model that we've tried, and unfortunately may be directly harming this pathway. So if you're needing another reason to be cautious about the pharmaceuticals, we know that these are changing the brain. And with the epidemic of Alzheimer's disease, as you've heard about from Dr. Iliff, I think it's so important that we start thinking a little more broadly for our own health and for the health of our patients. So here's a new image of our cross-section of the superior sagittal sinus. This includes the arachnoid villi, the dural lymphatic vessels, the CSF canalicular system. Oh my gosh, look how much more is going on in there. Did you ever believe it? Did you ever think we'd be finding new things? It kind of surprises me, and it also really humbles me, that we have so much more to learn. And anatomy, always with the osteopaths, digging on is figuring out and using the anatomy. And let's now do a quick quiz. So this is from Dr. Rasmussen again, and we saw this image before. CSF influx comes through that periarterial space. It flushes through left to right here in this image, back to the perivenous space, and metabolic wakes and come out. And which data, so I left these in here so you can read some of this, slides are available. And the CSF influx goes through aging and Alzheimer's disease, subarachnoid hemorrhage, stroke, traumatic brain injury, and idiopathic normal pressure hydrocephalus affect that inflow. But what affects the clearance? That's things like aging and Alzheimer's disease, subarachnoid hemorrhage, diabetes, and normal pressure hydrocephalus. And we honestly think that this is part of what is the transient viral or vascular effects of these post-infectious conditions. That this inflammation here is driving changes in the brain that potentially with the right therapy we can reverse, but potentially without, there's such great damage to the nerve here. So, and amyloid beta has been studied. This is affected through the aquaporin changes in those tau proteins. So for those of you who are interested in brain science, it's just such an exciting place to be. Now, after we proved it in the primate model, we needed then to prove it in a human model. This is from 2024, Dr. Yamamoto at the University of Oregon Health Sciences University. The perivascular space is a conduit for cerebrospinal fluid in humans. And so they asked wonderful folks who were undergoing intrathecal, I believe, chemotherapy for glioblastoma, if they could add some contrast into their studies and prove this concept. And we were grateful for the patients that said yes. And so this showed that the MRI, as the phases went through, confirmed everything that we suspected. So now we have clear human direct imaging of this process and flow, thanks to Dr. Yamamoto in October of 2024. So as I want to review, our cribriform plate is 60%. Those cranial nerves, meningeal lymphatics, and spinal nerves, along with the CSF canalicular system, make up a significant impression of the rest of it. And one thing Dr. Iliff mentioned in the video, and I want to tie this in just to finish here before we get into our parent technique discussion and how we can actually improve this, is the holy grail is figuring out how to do things non-invasively. And one of the things that's interesting in animal research is they often do things like that. So this is a photo of a primate study, and the primate and mice were used in this from Korea, and they showed these periorbital lymphatics on the nasal sidewall lymphatics that were affected, that as it turned, it came down here along the lymphatic vessels here, and it came down to the submandibular lymph nodes. And then it dropped down in, and it came through here. There was also a lot of lymphatics up in the hard palate and the buccal portion. And that the substantial total amount of cerebrospinal fluid outflow of the drain to the neck and the superficial cervical lymphatics. Then they manipulated it by a mechanical device that actually like pushed on it and did, I think, probably something that was far less beneficial than a hands-on osteopathic treatment with tuned-in energy, but they did mechanical stimulation of the cervical lymphatics through intact skin, okay? What did that do? The force-regulated mechanical device doubled cerebrospinal fluid outflow, and it corrected the drainage impairment in the aged mice. They had Alzheimer's mice that they did this to that got less Alzheimer's-y. And we've seen that from Chinese researchers who have done a lymphovenous anastomosis, a surgery where they connect those lymphatic channels back into the veins directly, and it sucks through those proteins. It'll restore some of that drainage, and the patients have woken up. And they're doing some of the research surgeries now in the US, but it is not yet like an approved procedure or a paid for procedure. But we have so much hope. If you can double the flow, think about flow dynamics in the body. And if we can consistently do that, that's the biggest thing that I think is from a perspective of an osteopath and an osteopathic physician, right? We want to make sure that the body can take its trash out. And as we take that lymphatics out, what we're also doing is we're returning the lymphatics information into our organs. What do I mean by that? The immune system that just fought that huge battle left all of those devastated warriors, right? And when the cleanup crew comes up, if they don't take the garbage back in so we see what the garbage is, then our body doesn't know what it's fighting. And that's part of what the role of the lymphoid organs are, including the appendix, including the tonsils, including the thymus, including the spleen, including the bone marrow. These are places where surveillance is. And so the lymphatics being impaired really, really affects this. But this slide is really a key one, and one I'd love for you to read the study. It was published in 2025. So we're really just at this forefront of starting to understand that maybe, just maybe, our hands-on techniques can really, really alter this flow. And I'm so excited for the research potential in the osteopathic profession. So let's talk now about the hands-on portion and how we can diagnose with accuracy chronic fatigue syndrome. So this is the work of Dr. Ray Perrin. He is a British osteopath, and he found that previous trauma, a physical damage or an abnormality, affected the perivascular spaces. That it was specifically injury around the nerves, olfactory, optic, trigeminal, or auditory, or along the spinal cord and alongside the spinal nerve roots, right? Think head, spine trauma. And how many kids have this, right? Like if you're in gymnastics or sports or football or contact, like car accidents, like the trauma is rampant, right? And usually our body can respond to it. That's correct. But what Perrin found is that all of these patients had some diagnosable trauma. And so they may not remember it all the way completely, but most of these people had something that was kind of like, oh, really? Like you survived that? And we'll talk more about that. Second thing that he found is that there was a buildup of stress. And it wasn't just in one domain, that they all had some type of emotional trauma or shock that got really worse. They had a buildup of physical trauma or pain or a second physical trauma. And then always he saw was an immunological trauma. That was an infection or a sensitivity, allergy, or a big response like an anaphylaxis. Also contributing to this was environmental trauma in people that lived in polluted areas or had more of a higher toxin burden, and other pathologies. As this all hits to the system, eventually the body can't handle anymore. And that's what we propose, or Dr. Perrin proposed, as part of the stages leading up to chronic fatigue. He said there was external stimuli, too much temperature, too much trauma, too much toxins. There was emotional stress, both good and bad. His research found that like something like getting married might be the most beautiful day in someone's life, but also a huge trigger because of the limbic system like not used to being able to handle this. And he said then the internal stimuli, blood pressure, disease, and this is affected both by chemoreceptors, so chemical receptors, as well as pressure and mechanoreceptors. And this is where we don't know what is the mechanism that's failing here in these lymphatics potentially. But via the limbic system, these all together affect the hypothalamus. And that's really your big hormonal regulator. So all of these patients tend to have problems with hormones, with weight gain, with chronic fatigues, other friends that go on, polycystic ovaries, like name it, and you can kind of weirdly connect it because of the mechanisms of hormones. He said there was distinct stages, though, that initially you'd have a period of sympathetic overload, that the stress wouldn't go away. And that eventually when that stress didn't go away or you didn't adapt to it, that it broke down your sympathetic. And that's when we go from that fight or flight run from the bear kind of to the freeze. Like think of the fainting goats, and that breaks that process down. We then see on clinical exam signs of retrograde lymphatic flow, things like megalymphatics, things like pressure points where there shouldn't be a lot of heat. And then Perrin proposed that this buildup of the toxins and the pressure in the central nervous system affect that hypothalamus. They dilate the ventricles, leading to chronic fatigue syndrome or myalgic encephalomyelitis. Perrin's initial signs that he diagnosed were, number one, that long-standing thoracic spinal problem. And he tended to see this with people with a sunken spine. They all had tenderness to those T4, 5, 6 segments. And what's innervated? What hangs from T4, 5, 6? It's the heart. The cardiac suspensory ligaments are there. And, I think it might be probable that some of these viral changes of those suspensory ligaments in the omentum are pulling on these bony tissues and causing an area of hardness and sunkenness in an area that's usually, supposed to be like a nice kyphosis. But we often see that these patients have a reverse of that, or a flattening. Number two, he saw, was throughout the breast tissue and sometimes in areas of the armpits, these areas of varicose lymphatics or megalymphatics. They weren't blue like varicose veins. They had clear fluid in them, but were more surface level, but would almost be palpable like a pencil or a string or a piece of yarn under the tissue in like discrete little patterns throughout, specifically the breast. Perrin also noted an area of exquisite tenderness in the upper outer side of the left breast, about 2 inches over, 2 inches up from the left nipple in most people, but kind of a third of the way between the anterior shoulder and the areola border. And it's this little area kind of right in there that as he palpates, he suggests you say, is there any pain, tenderness, sensitivity, or discomfort? And if that patient jumps off the table or gives you the eyes like, no, please don't touch it, it's weirdly and exquisitely tender. And this is actually with the area of the cardiac lymphatics and cardiac sympathetics. And he proposes that there's a crossover mechanism there. But interesting, the only group of patients that this was reversed were folks with situs inversus. So Perrin's point is something that is very clearly found on the left. Then lastly was the celiac plexus. And if you can take your hand and slide at that subxiphoid area and palpate there for heat, he found heat, tenderness, and discomfort in that area disproportionately high compared to people that did not have chronic fatigue syndrome. That area of the cisterna chyli. And then his fifth criteria is he found that with a craniosacral rhythm, which we're going to teach you how to palpate in our workshop, part 2. Stay tuned with me, myself, and Dr. Goldman. We're going to go through a really great patient case, and we're going to talk about how this treatment works, give you a framework, and teach you how to do a little bit so that you too can improve your diagnostic skills today. But he found that craniosacral rhythm that's normally like nice DeLorean doors opening, a nice breathing sensation, 6 to 12 cycles a minute, the inherent potency or the inherent motility of the system, if you're a non-cranial person, that was reduced. And you can feel that by low vitality, you can feel that by sort of a tightening, stiffening, or sort of a heaviness to the mechanism. Another curious finding in people with ME/CFS is that we saw back in 2001, Dr. Lang, that ventricular size had been seen to increase in chronic fatigue syndrome patients compared with normal scans. And so on the right side, you can see those larger ventricles in patients with chronic fatigue syndrome, and in the left side. He also saw things like Tarnov cysts and other cysts in the spine, may be a sign of this increased pressure as well. So those are patients that may benefit from some of these interventions as well. The fluids journey was produced by the choroid plexus, as you know, around the brain, and most of the CSF drains. Again, now we're understanding through the cribriform plate and the extraspinal venous sinuses, and drainage through the extracerebral and extraspinal lymphatics. So again, affecting that hypothalamus. And one of the things of that lymphangion, as we talked about it going through, imagine if that pressure was backflowing more than it could handle, and it overcame those valves. And this is that idea of the varicose megalymphatics. That formation happens, initially the lymphatic doesn't squeeze like a blood vessel where it's kind of moving all together. One squeezes, then the next squeezes, then the next squeezes, then the next squeezes. So it kind of moves it along there. That looks really cool on the camera. Or it moves it along there, okay? So as that moves through and you feel that backflow coming, it can't push it, and so it gets stuck there. And how does this look clinically? Well, here's how you're going to see it. You're going to see these varicose megalymphatics. They go along these vessels up here, and they're areas that you'll see too as this pulls in. I'm going to zoom in a little more. And these little areas here of swelling, and then the areas of collapse. Just fascinating. And these are people that will have striae as well, but they're not changing weight at all. You'll maybe notice some puffiness or breast size changes. One of our patients has like a very clear facial swelling. Like you can see his left side of his face and left side of his chest is like visibly bigger, different kinds of nasolabial folds. But these varicose vessels typically are through the chest, breast, and armpits. And there's a lot of varieties of them. You'll see sometimes down the arms or in the upper arms as well, kind of the bat wing area. And this is along the side of the neck there. So those megalymphatics are something we're going to talk about how to examine, and in our practicals we like look at how we diagnose those 5 signs. We also build that within clinical evidence and their duration of treatment to offer a clinical score that then helps people understand what they need to do to prevent decline and really reclaim their lives. We do though have some signs of unfortunately outcomes that are not as ideal as what we're hoping to achieve. And one of blessed memory is Lynn Gilderdale. Lynn is one of the first people who officially died of chronic fatigue syndrome in the UK system, which requires like physician diagnosis. Lynn was evaluated by Dr. Perrin. Her mom is a staunch advocate for ME research and in Lynn's memory. And we actually have some photos of Lynn's autopsy used by courtesy of Dr. Perrin. And I want to show you this, her right side, your left, the normal dorsal root ganglion on this opposite side. And then you see this big honker over here that's labeled dorsal root ganglion. And we found on autopsy, and we're seeing now more in imaging, a dorsal root ganglionitis. And if this is all swollen and leaking those inflammatory mediators right there into that perivascular space, right where all those central lymphatics are running, how is that going to affect feeding back into the system? And what's that going to do to the sympathetic chain? We think this is partially why all of the folks that have POTS and dysautonomia also have some of this sunken spine. And I'm curious from cardiologists, from neurologists, physical medicine doctors, others in the profession. I'd invite you to email me. It's at the end of this presentation about what you're seeing clinically, because I think these are wonderful opportunities that we need to study. And I want to show you what that physical exam looks like. This is the number 1 Perrin sign. And we saw the spondylitis in long-term sufferers of chronic fatigue. So you can see some of this like autofusions, right, as the spine breaks down. But notice here, a flattened and then the sunken mid-thoracic spine. Here's a little scoliosis. And you can see this mild rotation and flatness. And remember, because of Fryette's laws, right, when the spine side bends, it's going to rotate opposite. Or a single segment can rotate and side bend the same, but it has to be non-neutral. That's our Fryette's laws from the 1930s in osteopathy. So the spine's going to follow those. The case 2 here, figure 2, you can see this more rotation and flattening, also known as the forward head posture, the sunkenness. Like you'll see a lot of these people not be able to get that kind of hump out of their back, or have a lot of buildup in that stellate ganglion, kind of the buffalo hump area. You'll see this in young patients too, and we see this in kids with myalgic encephalitis as well. Females are more common than males, but we do have plenty of men who are dealing with this. So don't miss that in a man, I guess, is my only other point for you clinically. Since it's more commonly in women, we tend to ask them more about some of these symptoms. Men may be a little less forthright in coming through, especially about some of the big traumas, right? Like we want to be tough, but this trauma has to affect the perivascular space. These will also be the meningitis, the encephalitis, the like a lot of things can be this way, or stuff like recurrent concussions. Buildup of stress, again, always was an emotional, physical, and immunological trauma. And usually multiple, like there was a previous infection of Epstein-Barr, then the current infection of COVID, then, and we'll see this in some of our cases, hopefully. Again, all affecting the hypothalamus through that sympathetic dysfunction. And so, oh, hello. So how do we diagnose this then? Oh, I got the Holy Spirit today. So practitioners in a randomized controlled trial were more accurate using 2 of the 5 signs. This was validated in the British Medical Journal Open in 2017 with a reproducible physical exam finding by clinicians that Dr. Perrin didn't train. They were compared against a physical medicine rheumatologist doctor diagnosing, who was 47% accurate, and the accuracy using the Perrin criteria, these ones in front of you right here, was over 80%. And then when we got it down to, it really doesn't want to show you that slide. Okay, that there were 2 signs, the common postural disturbance. Okay. There we go. There was a common postural disturbance with redness, tenderness, and often an increased temperature of the thoracic spine. And Dr. Perrin will often do the triple response test of Lewis, and actually see if that wheel and flare will clear within the appropriate amount of time. You can also find heat along that back spine, and I like to assess for heat with the back of my hand as I move it along there. That can be a little more sensitive and easier to feel. And then the other area is in the epigastrum, and that area right through under the ribs here. And you would find this area of heat and some tenderness right along that mid area. I want you to see my nice red DO tie today. And that was Perrin's kind of initial vision. And as he saw these signs packing up, you can see that little area of redness that we see in the epigastrum. So the study then that they ran at another center a couple hours away, Dr. Perrin stayed completely away. They had a experienced physical therapist, a osteopath, and a resident, like an intern doctor, learn the Perrin technique and screen a group of patients against a standard physician exam. And these are the study results that he published in the British Medical Journal Open 2017. That the standard physician exam had 44% accuracy, and these other patients had been validated through a research tool, I believe the PFRS. But then we did the Perrin 5-sign exam. The accuracy of diagnosis was 86%. And then when we reduced it to just the 2-sign protocol, which is the celiac plexus and the thoracic changes, that it was 88.3% accurate. So I really want to share with you this wonderful data that the objective 2 is that, is there evidence here for manual treatment of the lymphatics? And I would like to propose that based on animal research that in primates, which is as close as we have to a human model as of last year, we know that non-invasive gentle manipulation of the cervical lymphatics doubles CSF outflow. And this is the baseline of Dr. Still's osteopathic principles, that structure and function are reciprocally interrelated, and that the body heals when mechanical obstacles are removed. So that was Dr. Jin and all in Nature 2025, the gentle mechanical stimulation of the cervical lymphatics doubled your CSF outflow. And I wanted to share with you a couple other articles that I think are required reading. And that's Dr. Iliff's Define the Pathway and Dr. Perrin's Manual Treatment article. So as we compare the effectiveness, that's the last thing I want to talk about. When we talk about evidence, we can talk about evidence of diagnosis, but we want to talk about effectiveness of treatment as well. And we want to compare it to what is currently available and currently the best practice. Best practices currently is duloxetine. It's FDA approved. These patients will be seeing psychiatry or often therapy to kind of help somatic processing. The mechanism for it is SNRI. It's a central pain modulator. Best data is we get about a 20% response rate. 40%, I think, in a few studies, but it was not more than a third of patients. When we did the Perrin technique and taught people how to do the self-massage and lymphatics, because typically the Perrin technique is primarily patient-driven. I would say 80 to 90% of it is them doing it themselves, and us supporting them along the way is that other 20%, and more of the advice and reading the book. But people can actually read his book and start to do this on their own for their own health. So I want to not gatekeep any of this information from you. The exercises that we're going to go through in our part 2 are available online, the parent technique, and I just think it's some really interesting data for people to be familiar. But what we're seeing is that as prognosticated by Dr. Perrin over the period of up to 2 or 3 years for some very severe patients, but usually months to a couple of years, we see about 70% functional gain in patients that undergo the Perrin technique. And we'll talk about what is the Perrin technique. But on day 1, we kind of diagnose, and we never treat the same day as the diagnosis. We'll treat osteopathically, but we won't do the hands-on work through the lymphatics. It is a structured prognostic score and a plan for the patients. And typical, the course is they're moderate or mild. It's a 6 to 12 month course of treatment. Severe is 18 to 30 months. But schedually, if they're sick enough, we do weekly for about 12 weeks, then bi-weekly for 12, then time out to monthly, and then quarterly. And we're gently working ourselves out of a job. Dr. Perrin really says that the hallmarks of the Perrin technique are following pacing first. Pacing, rest, meditation, and relaxation. That doing half of what you can is really the rule. And that's been validated in many, 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 many studies with ME/CFS. Please do not just send these patients to push themselves, tell them to just tough it out. They will do harm to themselves. And you'll see it clinically by more PEM. One of my goals is that we start this process, but the Perrin technique is very interesting. And how we know it's not a placebo is that people get sicker before they get better. And you're like, Ryan, you're telling me they rub on their neck like this and they open their nose and they pull it off their face and they get sicker. And I will say, yes, it's dramatic. They'll get like the flu and they'll get headaches, and there's a whole protocol to use supplements and hydration, EPA only fish oil to reduce the choline. Then we change back to a full omega-3 milk thistle or silymarin extract, which is a notorious liver support to help increase the clearance, and then sleep hygiene and sleep support, because we really, as we talked about with that mouse model, need the brain to sleep to heal. And it's just so important. Dr. Perrin published his theories on long COVID in a newer book called Through the Looking Glass. It has some of the information that's there. But Perrin said that the mirror of long COVID reflects the same toxic waters of ME/CFS and the same hope. And his shared mechanism is that SARS coronavirus, or the spike protein, triggers hypothalamic inflammation and leading to lymphatic congestion. So we've seen that about Perrin signs are appearing in about 70% of our long COVID patients. So I only apply the Perrin technique to the long COVID patients that meet the Perrin criteria. It's very interesting. We've seen it, and I again will case by case basis consider for other conditions, mental health things. We do use it for lymphedema, lipedema. It can be helpful for other lymphatic conditions as well. But one of the things that I think we need to really understand is how much lymph, doctors, can a lymph pump? And how important is it to change this? And I do want to inform you that I think it's great that we can still use our standard thoracic pedal lymphatic pumps, the Dalrymple, as others know it. And you see here that normal flow, how brisk it is. And can you imagine the effects to the body when this is your trash drainage system? I just feel bad for that patient, you know what I mean? And I think that really you can explain to patients that this is dysfunction in your central system, your central nervous system, but it's not all in your head. You know, this is not a psychiatric illness and condition. So in summary, I really wanted to show you that neurolymphatic blockages and their effect and pressure on the hypothalamus is a plausible, treatable mechanism that can explain ME, myalgic encephalitis, chronic fatigue syndrome, fibromyalgia, and long COVID. That hands-on osteopathic manipulative treatment and other non-invasive modalities show hope for improving the blockages and the drainage, including for conditions like Alzheimer's disease. And I want to show you how easily that you in the office, after today's lecture, can easily identify and screen your patients and yourself if you may benefit from this treatment to find solutions to improve your well-being. Dr. Perrin likes to say that this is a puzzle and that you're at the very, very center, that our corners are relaxation, pacing, rest, and meditation. That the Perrin technique and this fills in the sides for us to give us some structure, but that each person's therapy journey, from talk therapy to adaptogens to diet, electrotherapy or acupuncture, supplements, chelation. All of these tools are necessary and may be needed at different times, but we customize it for each person. No one's journey is the same, as you can see with the level of complexity. So what is the takeaway for you in primary care and in patient-facing specialties? Tomorrow, I want you to go there. I want you to palpate the celiac and the thoracic, okay? And screen 88% if people are having PEM. And it's pretty easy to screen, even have your MA ask about it. Please validate these patients. That when you show them the objective findings, take the pictures, teach their family members, validate that they need to rest and pace through this. Please teach them the pacing, share these resources, and teach them that like osteopathic doctors may be able to help. And we're gaining a lot more folks that are able to offer the parent technique and other hands-on osteopathic care wherever folks go worldwide. It's a real shift, though, from the management of symptom management and sorry you're going to be in pain forever to an idea that we can often functionally restore these patients, again, very slowly, very step by step. And as they get all of those toxins dumping, they get sicker before they get better. That's actually a really good prognostic sign. We hope this can give you and your patients new hope. So here's our list of references. This PowerPoint is available. We're going to talk a little bit more about the screening and diagnosis here in our workshop portion. We're going to take a little break before we come back, but please join us from this hands-on portion. We're going to talk about open heart, open hands, and being a guest in the home. Dr. Goldman's going to walk us through quickly how we palpate the craniorhythmic impulse. We're going to diagnose and screen with the parent signs and propose an autonomic nervous system balance sequence through 3 simple osteopathic techniques that anyone can perform, including you on yourself. So we're going to apply, recheck, reflect, and balance, and then teach some home exercises if we have time. So stay tuned for more. Thank you for joining us, and we'll see you in a few minutes. Hello, everyone, and welcome back to part 2, our hands-on laboratory section of our neurolymphatic lecture for the MOA Spring 2026. So welcome to Hope and Healing for ME/CFS. So this is our hands-on portion, but no touch experience is required. I want you to come with a little open heart and an open hands. We're just going to take a minute, check up on our shoulders, put our hands on our chest, take a big breath in and out. We're a guest in our own home today. So in this next section, we're going to palpate the craniorhythmic impulse and the cranial mechanism and assess vitality. And how I do that is by assessing from a 0 to 10 scale, 0 being very stuck, very restricted, and 10 being nice and flowy and open. And it's a objective, subjective measurement of my palpitation. We're also going to teach you how to balance this autonomic nervous system through 3 treatments anyone can perform very easily in your office during this exams even. The OA release, rib raising, and a functional sacral release. We're going to invite you to apply the technique, to recheck afterwards, again, a hallmark of osteopathic treatment. Reflect on your experience. There's a handout available, and I would like you, if you're doing the palpation, to encourage you to write about what you experience in each one of our 5 labs today and balance. And then we're going to introduce the home exercises and some self-treatment for your patients. So how does the treatment cycle work? And we're going to initially sense that craniorhythmic impulse, and then you're going to feel it take you into a passive range of motion. It's a spontaneous or induced lesion, and you'll feel it traced as the least resistance. As that moves into number 3, we sense a subtle gross unwinding, when the gross motion pattern sense is like a swift indirect technique. And then it'll reach number 4 at the bottom, a point of balance tension. This is where the restrictive barrier is held while maintaining motion present, or the complex around that to change. And then you'll in number 5, feel a release. It's a jolt, a jerk, a twitching, a melting. And you're going to maintain your force through that. 10 still required. But again, we're doing light force here. This is grams, not pounds. At the point of 6, you get to a still point where then notifying your tension, it just dissolves, and that part integrates in the whole. And then again, you're going to sense a new rate or rhythm. And that's how we kind of see this as a cycle, as a wheel. So here's a picture of us with Dr. Perrin at our recent workshop. And I'd like to now have us talk about a beautiful case study. And Dr. Goldman, would you like to take us away?
Thank you. Actually, this case study is about me because I've been under treatment for chronic fatigue. Much easier to talk about yourself than to take a patient and start talking about this because it is very overwhelming to patients. So, first of all, the big complaint was problems getting to and staying asleep. And when I felt good, I would do way too much, and then I'd crash for a day. And then I got brain fog, mostly in the form of forgetting names in particular, and then difficulty explaining to those close to me that I cannot do what I have done in the past. And that's really heartbreaking because if you are of my personality, which is more of a giver, what happens is that people that you have really tried to support in the past and just physically and mentally cannot do it anymore, they are oftentimes reading that as rejection. And then they start to reject you. And it's a very painful experience to go through. And then I started swelling globally, but mostly in the breast and markedly more so on the left side than on the right. Remember, we were talking about Perrin point on the left. That was there. And then celiac tenderness and stomach upset with bloating. I am gluten intolerant to celiac. And then aching all over with cramps in the feet, dead sensation in the legs, always worsened by cold. I wasn't really short of breath, but at times the breathing was difficult and the chest felt very fatigued.
And did this happen for you after COVID, Mary?
Yes, I was never officially diagnosed with COVID, but I did go for a test and was told that they ran out of tests.
Got it. Thank you.
Oh, past medical history. I was born with a particularly hard head after prolonged labor, sudden descent, and basically, I was a very quiet infant. They were talking about how my head always remained very smooth and very hard, and how I never cried, so I had to be awakened to eat. Autoimmune disease, my first one was at 13 months with hospitalization and a bone marrow that was done under the right patellar region. And I recovered just before my spleen was about to be removed. And then I had fatigue, runny nose, and congestion, headache most of the time in my youth. In my basement, I was exposed to black mold constantly. And my dad had brought home a relic from World War II that had a very suspicious mold that always caused me difficulty when I was around it. There was also a mono test around as a teen. I was very sick twice, and they could never get a positive mono test out. And they said it was mono, but never really could nail the diagnosis other than by guess. Then I had a severe head trauma at an age of 8. I actually fell out of a moving car on my head with my neck severely, suddenly side bent to the left, and chronic headaches that were very severe thereafter. And also a change in my abilities and my ability to think after that, mostly in the geometry field. And I would tell you that the reason that occurred was because the seatbelts used to allow you to go sideways. They wouldn't stop you from going sideways. And also because when you leaned on the door handle would open, the car door. And the car was going around a very sudden curve and came to a very sudden stop. I was also kicked in the back by a horse at about 16, resulting in a chronic rotation and pain above and below the T9 that Dr. Greenman, God bless him, fixed it. But the flattening of the spine continued both above and below that area. I had a broken nose first at 6 years of age with surgery twice in 1981 for nasal septal repair. I had breast cancer in 1989 with the right mastectomy, a failed implant attributed to celiac disease because they said there wasn't enough fat underneath the breast to be able to support the implant. There was also repair of lymphatic leaking vessel post-mastectomy that didn't occur until 2020. You know, doctors just don't understand it. They don't bother to listen enough to get a diagnosis, but I did find a plastic surgeon who would do that. So that occurred first as a leakage of a white material, which Ryan and I were talking about, and he believes that it is due to some chyle coming out of the abdominal region. Okay.
parent
Yeah,
score.
so on Mary's physical exam at this point, you got to hear a really beautiful history of kind of what I was speaking of before, is that these patients had some very significant both infectious, physical, and emotional traumas that I think thank you, Mary, for being so brave to share this. It's really, really powerful education. And her initial parent score, based on her criteria in her physical exam, I want to share with you, and that was a 3.5 out of 10, which is a moderate severe category. 0 is dead, 10 is normal, 1 is the most severe we will have, and that's hospitalized and bedbound. So I hope you never have to see a 1. I treat several 2s, and Mary scored at a 3.5, which is a mid-thoracic spine problem. She had the flatness and the sunkenness. We graded that a 2 on a scale of 0 to 3, or 1 to 3. It was a 2. She did have some breast tissue varicose megalymphatics, but I think because of the previous breast surgeries and other things, that flow had been clearly altered, and there was some fascial scarring throughout the chest that affected this. Previous surgeries as well for people. People even with just skin lesions removed, or little biopsies or lipomas taken out of those areas, you may see those affecting this flow. And parents' point, it was quite tender. We rated that a 2. Her celiac plexus region was rated a 1. And I graded her CRI as a 3 out of 10. It was moderate to severely impaired. And I described her cranial disturbance at this initial visit as CRI of 3 out of 10. She had a right inferior vertical shear, and there was SBS compression. And so typically that's that locked head. It's moving a little bit, but like there's not really anything there going, and they'll feel bad. These patients are not going to feel good when they see you. And I usually like to ask too, like, what's your battery charge today, for lack of a better term? And I'm like, are you 0%? Are you 100%? And most of my patients that in this phase are coming in and they're giving me 20 to 40 max, right? Like if they get above 50%, they're like, whoa, this is a great day. So just so that you know kind of where their energy is, because if you're coming in really strong personality too, as many of us do, these patients are just, they're just very sensitive. So Mary, continue.
Well, I had some other exposures, carbon monoxide poisoning during the time I was pregnant. I think what you really want to know is that I grew up in a ballet environment, and I was at an intermediate advanced level, meaning that the majority of people who solo in Shikkedi ballet are at the intermediate advanced level or slightly below it. So I was extremely busy at learning ballet when I was a youth. And then I cleaned the entire house since I was 11 years old. Even when I was working a 75-hour work week as a physician, I continued that as I raised my child. I also taught swimming as a young teen to young children. So we'd spend 3.5 hours in the pool each Saturday, coaxing them to dive off, or jump actually, off of a diving board, getting out of the way just in time so that we would encourage them to get brave. And then we would help them get in to the side of the pool. So for 3 hours after that, you'd be sound asleep. I'm also a black belt in Taekwondo.
So after we established this diagnosis, and again, thank you again, Mary, for sharing so much of your history, we started treating Mary with the parent technique. And I want to show you what that looks like, because I realize we haven't talked about that. And just as an overview, the first thing is we're going to actually grab this cribriform plate here up at the nasal base. We're going to pull down or push up. You're going to find which one feels better. Most people feel that pushing up feels better, but you're going to hold that, even resting your elbows on a table, pushing in a little there. And that we've seen releases the cribriform plate. And we want to start that up to about 3 minutes a day. Okay? As that starts to release, we're expecting that all to drain down here. So we're going to help it. And you can take your hands, gently fingertips, and just kind of like rain in the car wash. You know what I mean? Like you're just pulling your face down. And I know this looks so wild, folks. Like this is why we wanted to do this as our laboratory. And then you can also brush down along the back, and I'm going to show you kind of around the ears. The ears are areas that get really stuck. And then again, the submandibular lymph nodes, and then pulling it down here. And then lastly, taking your fingers one over another, and imagine a little roller. And I'm rolling towards myself, and I'm just going to gently push those down. I'm going to push those down. So I'm going to, um, yeah, I'm just going to pause that screen share. There we go. Yeah, as that's moving down. So then we actually work it through this little spot here, and then we split the breast into 3 different areas. And as we imagine it into the little 3 stripes, people work the fluid upwards through the breast with gentle stroking, up through the armpit, and then we're again pulling all of this fluid here. So as we push up and we push down, we're getting that concertina effect and pushing that here. Now, one thing I said is when people start this technique, including with the self-treatment, almost universally, if they're a good candidate for it, or if they start to respond, and this can be a little delayed too initially, but they may get a lot sicker before they get better. So I wanted to talk a little bit about how simple the treatment is, and I'm doing some cranial and some osteopathy, some rib raising, trying to open it up, but it's a standard indirect myofascial osteopathic practice that is my kind of standard treatment style. For those of you who've been treated by me, it's usually pretty gentle force and a lot of fascial stacking. But Mary, would you share with us what your symptoms were as this treatment started? And maybe kind of how you implemented the treatment? Because you didn't do much supplementation. You did a lot of ginger and water for liver support. And but I think you felt pretty badly very quickly. Is that correct?
I did. I literally was having a hard time functioning, mostly when I got home to do charts because I worked 2 days a week still doing OMT. And at night, I'd just come home and just flatten out. And then I wouldn't sleep well. And I get up in the morning, get it together, and go back to work on my work days. So just severe fatigue and spending time in bed wasn't helping me with the sleeping, but it was gradually starting to improve things. And I was gagging a lot at times. Now, I've seen patients do this. I've done this for some years, the gagging. Every once in a while, I eat something and I have to go into the bathroom and just cough stuff up. And it's usually a ton of very, very clear phlegm that's very thick and not bloody. And there's just a lot of difficulty with throat hurting afterwards. And then as it gets moist again, it feels better.
And
There's
they'll
also
get the lymph node swelling. You'll see a lot of sore throats. You'll see a lot of abdominal pain, a lot of headaches. This is where we then get into Dr. Perrin's recommendations on supplementation and some of the functional medicine support, other ways of kind of enhancing this detox. Because as you can imagine, if this much toxin and stuff is built up through all of these injuries, through all this time, as Mary said, going back to 6, 7, 8 years old for a lot of these insults, that as these are shifting in her body, that a lot of these make sense to what we have. And some of the things that are concerning, but you'll see electrical shock sensations, heaviness. I had a patient complain of internal buzzing, that actually the Perrin technique helped a lot. Ringing in the ears, tinnitus, hyperacusis, a lot of ear and otalgic sensitivities. These patients won't really be able to tolerate loud noises or loud lights, or they may need to kind of lay down a lot of the day. That's not flat on your back laying down. I like to tell people that's halfway on the side on your couch, and then the other half. Dr. Perrin found that laying on your side actually enhanced some of this lymphatic drainage. So there's ways we moderate this, but this is how we know the Perrin technique is not a placebo. Because ethically, a placebo should not make people sicker. And this makes almost everybody sicker. To the point is there's a big handout I give people that's like the side effects of the Perrin technique. And it's like, you will get sicker. Other things we tell them to do is not use anesthetics that contain epinephrine, because it will, the epinephrine, and I do think Botox is having an effect on this too, other things that change the neuromuscular junction. And it's weirdly, because of the interstitial fluid movement, which is kind of recently being described, there's a whole system of this that can push through the fluid to fluid side between and around the cells in the fascia. So there was a big toll to this, though, I think, as well. And Mary, do you want to talk about how people responded to you through the Perrin stuff?
I started being left out of family things, and since I was generally the one that did a lot of supporting them to begin with, cooking and planning, etc., that really hurt. And then the expectations that I could or would help people with their needs, just I couldn't do it. And it's very painful. The other thing that's extremely painful is when your colleagues don't understand why
Mm.
you're not jumping in.
No, and it's really important that we recognize that and the kindness to ourselves and our colleagues, because in medicine that kind of hero complex is something that's very common, and we all need a day off. We all need a break. We all need our shift to end at some point. So, and then did you find physical signs that changed through your treatment?
Oh, definitely. The left breast came down much faster than I ever thought it would be because it had always been there, particularly at Aaron's Point, where it was very tender. And I've followed a celiac diet for some time, but I still continued to have tenderness in the celiac area and sometimes warmth. And I worked very hard to get things done and ended up in bed for a very long time at night, which put me even more behind. And then because I want to dance or exercise or at least be able to go out for a walk, yeah, that wasn't good. Constant head fog, forgetting names, just feeling overwhelmed, but not at all times. Sometimes you feel like you're really together and you get really, really active. And if you don't understand, you have to slow down at those points and pace. You can really go down for a while.
Hmm. Yeah, and as Mary said, for the her first month of treatment, she felt much worse. What improved?
Well, there were some things like the back pain started to improve. I'm not really a big pain person, but I was getting to the point where I could not do a lot because I wasn't able to walk. I wasn't able to stretch. It took a long time before my shoulders and ribs released, and the brain fog comes and goes now, but it really keeps getting better and better. I think the biggest thing is I can lay in bed without feeling pressure to catch up all the time. And it just really feels good to lay in bed, which it was not doing before. People around me understand that I will back off from overdoing and are much more appreciative for the things I have done for them in the past and actually in the present. I'm clear about how I expect to be treated by those close to me, and I calmly explain my limitations. And I have a physician who supports and understands me, and that is huge.
Well, and I think that thank you, Mary, so much about how much this empathy matters, and we can't ever know what our patients are going through, but we can always be kind. Like my hero Dolly Parton says, it's an interesting time, and as you're returning to normal, you've made some really dramatic improvement in the past few months, mostly with just what maybe once a month treatment or even less frequent than that, and applying these techniques and treatments. How are you doing now?
Well, I'm doing some gardening. I'm walking the dog over a mile 3 times a week without feeling like I'm wiped out afterwards. I do yin yoga once a week, and it's extremely helpful. I have a good teacher. And then I do ballet class for about an hour and a half a session, 1 to 3 times a week, depending on whether it fits in the pacing allowance.
Hmm. Well, and Mary's 9 months in, and this is a picture of us from a couple weeks ago. And it's so wonderful. Thank you so much for talking about your experience, Mary. Anything else you have to add?
No, I just very, very appreciative that I can go continue to do my work because I do love osteopathy.
Yeah, and we want you to now to follow along with our handout that Dr. Goldman's going to talk us through how we palpate the craniorhythmic impulse. This is that gentle 6 to 12 cycles a minute, and she's going to describe a couple of different holds, including the Becker hold, and we're going to feel whether it's slow or shallow. Now, if you want to grab a kid or a pet to practice this on, we can spend about 6 or 8 minutes, but Dr. Goldman and I are going to kind of summarize these. We're going to invite you to pause, and we want you to follow ease here. Remember, if you're not used to this indirect style palpation, you're going to put on, you're going to feel what you feel, and you're going to back your pressure off 50% and let your palpatory experience change. It's important to be grounded and kind of centered and clear. And remember, Dr. Still, to find health should be the object of the doctor. Anyone can find disease. So, Dr. Goldman, take us away.
Okie doke. So turn the waters of life loose at the brain, remove all hindrances, and the work will be done. And give us the eternal legacy, which is longevity. That was Dr. Still. This is a gentle 6 to 12 minute, cycle per minute motion which expresses the vitality of the central nervous system. And the primarily longitudinal, symmetrical bilateral swelling that you feel may actually have a receding vector or vectors, which configure it into a cross as well. But usually it's the longitudinal that people feel. CV4 is used to change or still the balance of the cerebral spinal fluid pattern of fluctuation, allowing interchange between every single fluid and every single cell of the body, occurring in an instant and revitalizing every cell in the body. If the patient is totally devitalized, repeat weekly for about 9 months, after which the patient's vitality begins to return. So continue for 3 months until the patient is vitalized as they become recharged, kind of like recharging a battery. These are quotes, or summations of things written within Dr. Becker's book. So how a CV4 works? With chronic problems, the nervous system develops adaptations. The CV4 allows the patient to look under the adaptation and say, no, this is the way I really am. And at this point, the adaptation can be wiped away because the body can be pulled into a perception of illness as being part of them. And so you're removing that. So simply by having to relate to and deal with the disease, the body automatically encompasses it within the pattern of its own fluctuation. And what you're doing with the CV4 is removing that.
Thanks.
Sensing the CSF motion, start with the patient supine in a quiet room. Sit at the head of the table, cradling the occiput in the palms, fingertips at the suboccipital ridge. Can you see that? Okay. Soften the hands as if your hands were seaweed on the ocean, just floating on the top of the water. Let the tissues glide. Listen with your fingers for a longitudinal tide. And they're saying at a rate of 10 to 14, but I think you can actually go 6 to 12 is more common. And that's permanent in a healthy adult.
Now,
Okay.
this is similar to the Becker hold, where you're
Now, the
cradling
Becker hold involves occipital cradling. So what you're doing with that is the patient is supine again. Operator's hands cradle the occiput, adjusting to relax the upper cervical tissues. And then your third finger is generally over the OA. So you're going to be a little below here because we don't have a cervical spine here. Okay. And then what you're going to do is cradle with the other 2 fingers underneath the occipital region. And the other 2 fingers are simply supporting the head on the lateral surface. There is some variance with practitioner hand and patient head size in the way that you place your hands. But the thumb and second finger comfortably control the head so it does not turn. So
And my favorite is that the thumb is on the occipital mastoid suture. It's just right in there behind the ear.
That can be very helpful.
Can you turn it sideways for us, Dr. G? So
and
we
you
can
want to
see.
see an
I
occipital.
want to see where your hand was on the side.
Occiput, and the mastoid is off of the temporal bone.
Can you show us your hands, please, instead of the
hand?
anatomy on the Becker hold?
Yeah, okay. So I'm here, and then I'm picking up around the top, but the bottom is catching the occipital region. The third finger is somewhere along the OA junction.
You're scooping here, and your thumbs are coming up behind the ears.
Right. So looking at the side view is awkward. There we go. Looking at the side view, the head is slightly raised up, and you have a pretty good weight falling onto your hands.
That's great, Dr. G. Thank you. We're having a hard time visualizing, so I'm going to move through and we're going to talk through this because we're a little out of time right now. So we're going to observe that CRI, and we're going to see that it has subdued swelling and receding. So if it's subdued, like it's changing that motility, which is part of the 5 phenomena of that primary respiratory mechanism. When the mobility is reduced, you'll find the patient sympathetically dominant. And when the balance is full, it'll be more parasympathetic dominant. Do you have anything else to add there, Dr. G?
I think that's perfect.
So lab next, we're going to balance this autonomic nervous system. So As we use the vault hold and treat, it's going to go into that cycle of treatment. Then we're going to encourage you to go down and check and then lift up the ribs to the ceiling. You can do that from the side. You can do that from just the back. Try this on your kid or your dog. And you're going to lift the ribs with a slow oscillation, 2 to 3 minutes each side if you want. And you're going to wait to feel the softening. But you may feel this really helpful around the cisterna in the back, and you may go up in the entire spine. Stay into the gutter on the ipsilateral side of the muscles, though, because we're really working under those rib heads where that sympathetic chain works. Then lastly, you can get a sacral hold. And that is the sacrum sits here. You can let it sit into this cupped hand, all right? So that it's like a little baby rocker, and that it fits right into the shape of your hand. And you can gently compress that forward, sometimes with your arm over the ASIS. And as that happens, it doesn't want to show me that it zooms us in. Thank you, Zoom. That hand sitting there can lift that sacrum superiorly in a supine patient, and that you can take it in indirect motion and monitoring locally as well as globally. So when you see releases, that's going to show like yawning, sighs, warmth, changes in breathing and slowing in heart rate. And Dr. Sutherland's quote here is, when the fulcrums are synchronized, there will be peace and harmony. I want you to pause this and try that. But be careful and watch for a few signs. What you want to make sure you're not getting is any jaw tension or dizziness. You got to work to achieve that calm. This is that patient experience that they can relate to, so that it's better that like you're not saying, relax, calm down, chill out. It may give you a better evaluation if you can just embody that, kind of practice that. And jaw tension or dizziness is a sign that you're putting too much force in, or that the membranes are not happy. If people get nauseous as well, is another thing I want you to check and get rebalanced, and we can help. So once the patient sees that tension release, you're going to evaluate that potency. And I just want you to sense from the beginning kind of where it was, and then sense after we do these 3 things. If you have a question about what you're doing, follow the ease. It'll be in the direction of this inherent motion and almost feel like it's kind of grabbing you and pulling you like a fish on a little thing. And you're like, over here and over here. That's correct. But stay on the back side of it. Rib raising, how does it work? It's decreasing the sympathetic firing in those T1 to L2 regions. And we're going to lift those again, 2 to 3 minutes each side, especially helpful around the cisterna. And as we balance the sacrum, that parasympathetic tone from S2 to S4, we're going to see the sighing and warmth. And this really helps your pelvic floor patients as well. And Dr. G, I want you to talk about what our lab 5 is here. What's the most important thing that I say? Pacing.
For any given activity the patient plans, including if you're going to watch a TV show, ask the patient how long they think they could do it without making themselves fatigued. And then if they tell you an hour, they can only watch for half an hour. And that's true for any activity.
We're going to avoid this crash at all costs. And your battery on your phone dies, you've got to charge it back up before it'll turn on. And we don't want these patients having to recharge their battery every day. Like, it's way more hard on their system. So what are these 5 signs? Thoracic flattening. What does it mean, a rigid tender segment? You can screen for this on your osteopathic exam. It means sympathetic facilitation. Those varicose megalymphatics, that's beaded cords in the chest or neck. They'll feel like pencils in these upper outer sides. You may see them visibly. That's lymphatic reflex. Perrin's point is 2 to 3 centimeters superior lateral to that left nipple around the cardiac lymphatics. That's thoracic duct and cardiac irritation. The celiac plexus in the subxiphoid area means that the visceral sympathetics and the cisterna are overloaded. And that slow or uneven rhythm, too fast or too slow, right? In the osteopathic 3, we get to the just right in the middle. That's the impaired drainage and autonomic imbalance. I want you to remember that applying this now, you can practice assessing these. Feel for heat, tart changes, tissue texture change, asymmetry, restriction in range of motion, and tenderness. You'll see trophic changes here, the red, ropey, hot, or cold kind of, and make sure this is light touch and clear consent with documented findings. Here's what you're looking for once again. And as you treat through within the cerebrospinal fluid, there's an invisible element that Dr. Sutherland referred to as the breath of life. Now I want you to visualize this breath of life as a fluid within a fluid, something that does not mix, something that has a potency, as the thing that makes it move. Is it necessary to know what makes the fluid move? Visualize a potency, an intelligent potency that is more intelligent than your own human mentality. And lastly, both for yourselves and your patients, we want to emphasize self-care and pacing. And we're going to leave you with this practice today, is that hydrating, breathing slowly, gentle movements, prioritizing your sleep, which is the biggest thing you can do for your lymphatic system. What? Sleep. And breathe. Pacing too. And again, one thing we didn't clarify is that the abdominal diaphragm, as it breathes, is the largest pump of lymph. So deep breath and walking are irreversible. Those lymphatic shaker things can be really hard on people with megalymphatics because gravity pulls all that lymph down. So tell your patients to be careful. And be careful with lymphatic massage. Not that it can't be helpful, but you may be crashing, your patients may be crashing themselves out with lymphatic work that's not gentle enough. One thing people are always surprised about is how gentle and slow and small the parent exercises are. He recommends doing them for 5 to 10 minutes at night before bed, and that's it, like once a day. So these patients really want to do a lot, and they get feeling better, and then they want to do more. And it's so important to remind them of the truth of their illness, how sick they are, and that the patient self-treatment is really the key here. Dr. Still said the cerebral spinal fluid is the highest known elements in the body. And unless the brain furnishes this fluid in abundance, a disabled condition of the body will remain. He or she who is able to reason will see that once the great river of life must be tapped and the withering field irrigated at once, or the harvest of health be forever lost. So let's teach you the exercises briefly, and we'll say goodbye for today. So 3 times a day, I want you to sit up upright on a firm surface, and you are going to put your hands behind your neck, elbows forward, and we're gently going to encourage you to rotate 15 degrees to the left and right, each direction. No more than 45 degrees total. Breathe in as you rotate, breathe out as you come back. And you're just going to do up to 5 or 10 twists. Then bring your arms down over your chest, making a cross here on the shoulders. We're going to do the same thing. Again, only turning about 15 degrees to offload the spine and those spinal nerve roots. This feels really good for people with chronic fatigue syndrome and will help them kind of get their brain back. And you can see how Dr. Goldman's doing a little bit more of a oscillatory. I'm doing a little bit slower. But everything is correct for your body and lymphatics. And fluid baths, floating, those are all helpful things as well. Now lastly, you're going to take your arms, drop them down like this, and you're going to twist just from here. And arms crossed. That's right. Arms crossed in front of you, hugging your shoulders. Sorry, I didn't flip the slide. And then arms folded down at the waist. And if you're able to stand up then, we finish by rolling the shoulders forward 5 times and backwards. 1, 2, 3, 4, 5. And if you do that, that sequence should take about 1 minute. I think it took 2 because we explained it. Now our breathing exercises. And Dr. Goldman, do you want to teach these?
Sure. So they're used for long COVID or difficulty breathing. And that's more common than people admit or even pay attention to. But it's particularly bad in patients that have long COVID. So three times a day, repeat these 10 times. Sit down with your hands placed across the sides of your neck with your elbows held out. Fully breathe in. Oh, elbows held out. I'm sorry. Yeah, that's correct. Big breath. Start to breathe out slowly through. Sorry, got to get rid of this phone.
Oh, yeah.
Righty. Start to breathe out slowly through the nose while bending your head, neck, and upper back forwards and down. With the elbows gently closing in on each other, and hold the breath for 3 seconds in this bent sitting position. 2, 3. Then breathe in through the nose, slowly straightening your back while pushing elbows forwards, upwards, and out. And you do that 10 times.
So you're seeing too how that opens up those ribs, that keeps that going. So this is on the last back page of your handout along with the self-care exercises. There's a lot more information to be had, but we unfortunately are out of time today. So we hope you're going to go and enjoy some puppy time. And we wanted to share our contact information for myself and for Dr. Goldman. More information, videos of these exercises and the self-help guide available for your patients complimentary is available at theparentechnique.com. We're happy to share resources with you. Myself and Dr. Goldman are both licensed Parent Technique practitioners. We're hopefully going to be bringing Dr. Parent in for more trainings. And we're just really excited to share this new science and see how we can help people continue to get well. Thank you so much. We look forward to seeing you soon. I'm Dr. Ryan Christensen. Thank you for joining us today.
Thank you.